Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA Primary Exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this is James at GasGasGas. Welcome to the next episode of our local anaesthetics series, and today we're covering cocaine. This seems to be typically used by our ENT colleagues. The next episode in the series is going to be on prilocaine, and I'd just like to take this moment before we get stuck into the show, just to remind you guys there's a donate link in the show notes and on the website. If you're helping fund my podcast hosting, my web hosting, etc. Very much appreciated. Anywho, history of cocaine. So, cocaine is derived from the cocoa bush, and that bush is called Erythroxylon coca. It's a South American native plant, and it's probably original to the Andes, and has been used for a very, very, very long time, whereby indigenous tribes chew the cocoa leaf, and that's something that still happens today. But cocoa leaves are probably not very useful at rubbing into tracheas or intranasal cavities. But in 1855, it was extracted and purified, the cocaine element of the cocoa leaf. But then Carl Koller in 1884 used it to topically anaesthetise an eyeball, and that's probably one of the first documented uses of cocaine. But we're not really the most prolific eyeball anaesthetisers as anaesthetists. We do like spinal anaesthesia though. And the question is, before we pile into cocaine, I just wanted to talk a little bit about the history of cocaine and spinal anaesthesias. You might have heard the story. I think I've heard parts of the story. Here goes, and this is courtesy of the Association of Anaesthetists of Great Britain and Ireland. There's a link to the article on their webpage at the bottom of the show notes. But it all bears down to, did it really involve knees and cricket bats? And the answer is, it involved shins and another implement. So, kicking off, who stuck local anaesthetics in the intrathecal space first? So there's an American called J. Leonard Corning. He was a neurologist. And he injected a dog in 1885 in its, what he was expecting to be spinal canal, and a human a bit later. But looking at the needles he was likely using and his anatomical understanding, assuming that epidural vessels would carry agent to the spinal cord, he was likely injecting in the epidural space and getting some clinical effect there. However, a number of fortuitous events came together. So Heinrich Irenaeus Quincke needle fame, in 1891 started lumbar puncturing people to drop their intracranial pressure. And in 1898, August Beer of Beer's Block, and now spinal anaesthetic fame, in my mind, injected 15 milligrams of cocaine using Quincke's lumbar puncture technique for a patient with a tuberculous ankle. And the surgery went well, but the patient did have a headache and vomiting postoperatively, which you would somewhat expect, seeing it was probably the needle the size of a scaffolding pole, or thereabouts, I'm sure. However, it worked. He did this 5 more times in different patients, and then he figured, well, I best actually understand this in a bit more detail. My patients maybe aren't the best at describing the clinical onset and depth of anaesthesia to him. So he convinced his assistant to have a go at injecting local anaesthetic into his spinal cord. So his assistant had a go. However, they anecdotally spill a lot of CSF, and I think August Beer decided that perhaps roles should reverse here. So he successfully cocainized his assistant's spinal cord. And there are a number of ensuing tests. Needle pricks in the thigh, apparently some fairly robust testicular traction, and then hitting poor assistant in the shins with an iron hammer. I'm sure there's no parallels to draw with current practice. However, they both did have headaches and dizziness afterwards, and as you would expect, the test subject possessed a number of new bruises. But this was perhaps the first documented evidence of some spinal anaesthesia being described fairly clearly. The last thing I want to say is Theodore Touffier caught wind of this and took this technique and popularised it. He also went on to coin Touffier's line, which I hope we all know of, which is the line that intersects the L3-4 interspace from the tops of the iliac crests, which is a great way to approximate where you are on someone's back. Although I think there's some evidence that says if you ask someone what interspace did you just do that injection at and then count it, it appears that we're not as accurate as we think we are. So that was a little sojourn into the history of spinal anaesthesia and cocaining eyeballs and spinal cords. I'm sure they didn't abuse it at all. That would be our dear fellow Halstead, poor bloke. Great surgeon, troubled with access to such illicit agents. Anyway, cocaine. Cocaine is a naturally occurring sympathomimetic alkaloid. It comes in two varieties. There's cocaine hydrochloride, that's water soluble, it's crystalline powder, probably what we're mostly using in hospitals, I imagine. And then there's freebase cocaine, and this is crack cocaine. And this is the version that gets smoked. Yummy. Not for the faint-hearted, I'm sure. I should probably take this opportunity to say that cocaine is bad, and we're all going to learn about how devastatingly bad it is for you, especially in large amounts, or if you've got any sort of whiff of hypertensive or atherosclerotic disease. Drugs are bad, kids. Don't do them. Cocaine hydrochloride, we're going to be clinical about this, is an ester classed local anaesthetic. It classically comes as a 10% topical spray or solution, and it is clear and colourless, and it has a molecular weight of 311, if you're interested in that. How does it work? It actually does quite a few different things. So from a local anaesthesia perspective, you've guessed it, it is a sodium channel blocker. And this is a Vaughan-Williams 1C effect. It also causes vasoconstriction locally, and that's why people who snort cocaine end up with nosebleeds, as they damage and necrose their nasal mucosa, and they can eventually end up with perforated cartilages in their nose. It also is a sympathomimetic, as I alluded to moments ago. You could describe it as a central monoamine reuptake inhibitor because it blocks postsynaptic reuptake of dopamine, noradrenaline, adrenaline, and serotonin. And you can imagine if we're accumulating those four agents in your synaptic clefts, in your central nervous system, a number of things are going to happen. As we all know, dopamine, reward, euphoria, feeling great. Serotonin, again, euphoria, feeling great, feeling like you're on top of the world. But then noradrenaline and adrenaline, they're going to make you more awake, but also they're going to end up having other effects on your centrally mediated blood pressure through your locus coeruleus, etc., whereby you end up tachycardic, hypertensive. But I'm getting ahead of myself. We're going to go through that in a moment. What do we use it for clinically? So I think it used to be used quite a lot in dental anaesthesia. However, now they just use those clever little glass ampules of lidocaine and inject to their heart's content. But it's still used a lot in ENT surgery, and that's because of its potent vasoconstricting effects that really do open up the nasal cavity and allow the surgeon to get in there without scraping along too much mucosa. It also controls bleeding in this clinical operative field, which, when you think if you're manoeuvring around a nasal concha and there's not much room, any bit of bleeding wrecks your surgical field. We do not use it for eyeballs because it causes corneal irritation. And I think those indigenous tribes, although I'm sure they're probably somewhat addicted to the cocoa leaf in some regards, no judgments here, folks, chewing it helps altitude sickness, but it's certainly not first line. And can't imagine getting tachycardic, hypertensive, a bit of an increased respiratory rate, and feeling really great and on top of the world when you're literally on Everest, puts you in a very safe frame of mind. Anyway, the dose. So 1.5 milligrams per kilo as a topical dose, which has a rapid onset. If we're putting it in someone's nose to try and contract that mucosa down and anaesthetize it, about 30% of the dose is absorbed. And you see a peak plasma concentration of that intranasal dose at about 30 or 40 minutes into the surgical case. Interestingly, if they've used it in the trachea during bronchoscopy, it demonstrates slower uptake and you can see effects almost 2 hours later. And of note, from a cocaine spinal cords perspective, it doesn't really last long enough to make it useful, like 30 to 40 minutes is what's quoted. So, pursuing pharmacodynamics of cocaine a bit further, we need to think about the side effect profile, having spoken about its effects. From a cardiovascular standpoint, it causes a tachycardia and it causes hypertension. Now, those in itself increase myocardial workload, as you know, tachycardia, less time in diastole. The heart on the left side, the left ventricle, is perfused in diastole only. Right ventricle is perfused throughout the cycle. Hypertension, increased afterload, that means increased LV tension and therefore work. But then we add insult to injury because we cause coronary vasoconstriction and sometimes even coronary vasospasm. So now we've got a heart that's working harder, that's getting less blood flow, and you can see that that's probably not a great combination. It also has positive inotropic effects on the heart, so it's now squeezing harder against more pressure faster. And you can imagine that this is a recipe for cardiovascular problems. If they get coronary vasospasm, they're going to get myocardial ischemia. If they don't get the vasospasm, they are still at risk of ischemia. Younger people might tolerate that, but anyone who has any whiff of coronary artery disease is at a higher chance of problems. Imagine the anecdotal person who does cocaine at a wedding. They used to do cocaine when they were younger and they just thought one last hoorah, and then down they go as a sweaty pile of spuds and off to hospital they trot with their new chest pain. Daft. But also, we focused a lot on the heart there, but remember, hypertension means increased tightness of vessels throughout the body, and you can get vasospasm of other vasculature, i.e. your GI tract, etc. From a respiratory perspective, it causes tachypnea. This is from the sympathomimetic side of things. You can get respiratory mucosa necrosis, i.e. your nose, and for those unfortunate individuals who are smoking crack cocaine, chronic consumption of crack cocaine leads to crack lung, which is a fibrotic awfulness. I haven't read about what that mechanism may be, but I imagine if you're causing vasoconstriction in your nose with cocaine, you might cause it in your lungs and hypoperfuse your poor little alveoli. But don't quote me on that. Central nervous system effects. So, you'd hope, euphoria. The patient feels great. Oh, I've had my ENT surgery. Wow, yeah, let's go. But also, anxiety, paranoia, and it can trigger psychosis. It can cause people to have headaches. They get mydriasis, i.e. big pupils. And if you're unlucky, that hypertension can make you have a subarachnoid hemorrhage. And if you get cerebral vasospasm or a subarach, you might have a seizure. It's not really sounding like a strong sell here. What about GI effects? So I mentioned the potential of ischemic GI tracts. However, if you have an unlucky person who's ended up having to try and smuggle cocaine in packets that they've eaten, and one of those packets bursts, that's going to be very neat cocaine. It's not going to have been cut because they want to try and transfer the largest amount of pure stuff as they can so they can cut it on the other side. So someone who's now gone off and done a full cocaine bear, ingested a load of cocaine, is bad news. You will certainly end up with GI tract ischemia if you survive the physiological insult of that much cocaine. And then from a metabolic or endocrine perspective, I mentioned it's a monoamine reuptake inhibitor. That means, amongst other things it can cause a serotonin syndrome. So if the patient's already on fluoxetine, etc., and then they're having cocaine as well, they might end up quite full of serotonin and end up in that agitated augmentation state where they're tremulous, excitable, they get tachycardic, they get hypertensive, but they get pyrexia, and that pyrexia can be lethal. From a clinical perspective, I'm sure you can already guess what the contraindications to cocaine use might be. And I would say that anyone with ischemic heart disease, cardiovascular disease, or uncontrolled hypertension really should not be having cocaine in their nose courtesy of the ENT surgeons. But also porphyria is something to not administer cocaine to. And porphyria is just a spooky thing that is intolerant of many the odd thing. So that was the pharmacodynamics of cocaine for the FRCA primary exam. I think it would be an interesting conversation to have in a viva, but I imagine it probably is fair game because it's a local anaesthetic that is used and has an interesting side effect profile. So from a pharmacokinetics of cocaine perspective, the real relevant one is onset time intranasally. And we know that it takes about 5 minutes to start working. The vasoconstriction that it mediates slows its uptake, but it also, in some way, prolongs the onset at the site of action that we're interested in. From a distribution perspective, cocaine is 95% protein bound, has a pKa of 8.6, and that seems to work out that there's around 6% unionized, so that fraction's quite low. From a metabolism perspective, the important thing to remember is esters are broken down by esterases, and that's a trick in the name for all you people trying to remember stuff. Esters broken down by esterases, shock horror. The interesting thing about cocaine is that the liver esterases can also get involved in clearance. There are a number of metabolites of cocaine, which are somewhat hard to pronounce. So benzoyl lecagonine, ecagonine, methyl ester, and norcaine. However, the interesting thing is when someone has plasma alcohol and plasma cocaine, those two bind up quite happily, and you get something called cocaethylene. This is much harder to break down than standard cocaine, and actually is more potent than the cocaine itself. So if we return to our anecdote of someone at a wedding who shouldn't have been doing cocaine but chose to, even though they were a bit hypertensive now and take ramipril, and they've been drinking and have cocaine, you can imagine that that is a suboptimal situation. I'd like to point out that that hasn't happened to me, but it's just sort of an anecdote type thing that you hear on the grapevine. Offset. So perhaps one of the saving graces of cocaine is it only lasts for about 100 minutes. If it's inhaled, it lasts even less than that, 5 to 15 minutes. And that's because we need to remember that the plasma esterase system is a exceedingly busy metabolic system that is vacuous in nature. You could almost throw a sofa at it and it probably would break it down if that sofa was made of ester molecules and had sufficient surface area, etc. When it's administered nasally, it takes about 60 to 90 minutes to clear. I'm going to talk a little bit more about cocaethylene in a second. Now, the other thing we need to think about is what prolongs what. So cocaine and sux probably prolong each other as they compete for choline esterases. Note that there are plasma esterases and plasma pseudocholine esterases. There's always going to be a little bit of crosstalk between everything, although we all know that proteins have certain preferences for other molecules, but if there's enough of that molecule around that every now and again something binds, you're going to see a bit of activity there. Complications of cocaine. I'm now thinking you're the anaesthetist on call, you've just been called to someone who's in VT because they've had far too much cocaine. And remember, any cocaine is technically far too much. What are you going to do? So ToxBase is really quite useful, and there's loads of other information on the internet. The important questions to go through your mind with anyone who's coming with cocaine toxicity is if they are agitated, give them benzos. If they're having seizures, give them benzos. If they've got hypertension, give them benzos. And if they've got hypotension, well, you could give them fluid, but you need to start thinking that they're going to have myocardial dysfunction, impending badness, because really they shouldn't have a low blood pressure, so something has happened. What do you do if the benzos aren't working? Well, probably more benzos. From a high blood pressure perspective, if they're having myocardial ischemia, do not just beta block them, because you'll end up with unopposed alpha and you can actually make things worse. ToxBase mentions labetalol, although some other sources steer away from labetalol to start with. If someone has chest pain, give them nitrates, so give them some GTN. If that works, and then their pain comes back, start a GTN infusion. Interestingly, cocaine also improves platelet function, improving how a platelet responds to ADP and inhibiting plasminogen, which, as you can imagine, if someone who's got coronary vasospasm, sluggish flow in their arteries, maybe some slightly gnarly artery, and now you're telling me that their platelets work better, you might go from having coronary vasospasm to relieving that with the benzos, but then having persisting ischemia because actually they've now got a lump of gunk in their coronary that wasn't there to begin with. Another important thing with a patient presenting with chest pain from cocaine, don't just immediately pile into thinking it's the coronary vasospasm, it's their myocardial ischemia, because someone with slightly crusty arteries who takes cocaine and gets hypertensive might end up dissecting something. So what about your patient who's now taken loads of cocaine, they've had some chest pain, and now they're in a ventricular dysrhythmia? Well, ToxBase would suggest that bicarbonate, as in sodium bicarb, 8.4, 100 mils, either very quickly if they're in cardiac arrest, or slightly more thoughtful infusion if they're not and they're conscious is a good way to try and help counter that sodium channel blockade, because if they've got a dysrhythmia, then they might have enough cocaine in their system to block the sodium channels on their cardiac conducting system. There's reports of lipid emulsion rescue being used at a case report level to try and counter that, which sounds a little bit like local anaesthetic toxicity. And I think there's a website for lipid emulsion rescue therapy which has case reports of giving it a go when nothing else is left to do. I'll put a link in the show notes because that's quite interesting. Now, I don't want to go too far off-piste thinking about cocaine toxicity. Just bringing it back to the patient in front of you in the theatre. If they've had their nose packed with cocaine for the purposes of surgery, and then they've woken up and they're a bit agitated and then a bit hypertensive, maybe a bit tremulous, a bit tachycardic, and not complaining of pain and muddled, then you need to think that maybe they're a bit cocaine toxic. Now, ideally, that's been avoided because you've not administered too much cocaine to their intranasal space, courtesy of the ENT surgeons. But in that case, absolutely reach for some benzodiazepines. Clearance is about 100 minutes. Hopefully they've not been drinking alcohol and therefore ended up with that cocaethylene stuff. Cocaethylene apparently has slightly longer half-life, approximately double that of cocaine. There's a little bit of research out there, although not a lot. Something out of Yale experimental pharmacology, which found that for equimolar doses, the subjects weren't terribly able to differentiate between if they'd been administered cocaine or cocaethylene. There was another patient group administered cocaine as an IV infusion who were co-administered alcohol. This identified that they found that the effects were more pronounced, but also there was evidence to suggest that about 17% of the cocaine became this cocaethylene stuff, and that there were alterations in clearance to those metabolites into the urine, which would suggest that it's taking longer for the plasma esterase system and the liver to start tidying up that molecule. Anywho, that was probably everything you certainly need to know about cocaine for the FRCA exam, and also a little trip down memory lane with spinal anaesthesia and the things that you should probably be having working through your mind if you're going to a cocaine-flavoured cardiac arrest or poorly person. But have a look at ToxBase as well. Anyway, I'd like to say thank you very much for listening. You've successfully got to the end of this podcast. I hope you enjoyed it. Next week is Prilocaine, and I'll see you guys then. Cheers, and thank you very much. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.